I'm Enrico Castillo. I'm one of the Associate Residency Program Directors. I'm also a researcher in the Center for Social Medicine and a psychiatrist at the Department of Mental Health, and it's my honor to introduce our grand round speaker today, Dr. Francis Liu. Dr. Liu wanted me to mention that if anyone wants the presentation for today electronically, they can reach out to Dr. Helt, or they can find me after the presentation. So definitely let me know. Dr. Francis Liu, I've had the privilege to be mentored by Dr. Liu since medical school, and at that time I was a medical student in Pittsburgh with a new interest in psychiatry, and I didn't have mentors that looked like me or that were interested in the things that I was interested in. And at that time I found Dr. Liu's 2002 article in Academic Psychiatry titled "A Psychiatry Residency Curriculum About Asian American Issues." And reading his work and learning about his career showed me the field of cultural psychiatry and also what can be achieved if one follows their passions. Since that time, I've had the honor to know Dr. Liu first as my mentor in the APA Medical Student Mentorship Program, and then as a colleague in our APA Council for Minority Mental Health and Health Disparities. And as a resident, I came to Dr. Liu at a crossroads in my career, and I can still remember what he said. He told me to follow a career in helping the most people that I can. And that simple advice and that conversation is still something that I carry with me. And Dr. Liu's career perfectly embodies that, connecting to others and a life of service, as he put it at yesterday's film event. In Dr. Liu's career, he's pioneered new and very important directions in equity, diversity, and inclusion, in research, in education, health systems transformation, national accreditation, and educational standards. Dr. Liu is a national leader in the areas of cultural psychiatry, psychiatric education, mentoring and career development, religion, spirituality, and mental health, and also film and psychiatry. He's the Luke and Grace Kim Professor in Cultural Psychiatry Emeritus at the University of California, Davis. He currently serves on the board of directors for the Society for the Study of Culture, Psychiatry and Culture, and is the past board member of the World Association of Cultural Psychiatry. Since 1993, he's been a member for the Group for the Advancement of Psychiatry's Cultural Psychiatry Committee. And in 2008, the American Psychiatric Foundation awarded him one of its Advancing Minority Mental Health Awards, and the Association for Academic Psychiatry awarded him its Lifetime Achievement Award. In 2016, he was awarded an APA Special Presidential Commendation for extraordinary leadership and outstanding contributions to the field of cultural psychiatry, and he's presented at every APA meeting since 1984, including workshops since 1995 on the topic that he'll present today, which is the cultural formulation and achieving culturally competent care. So please join me in welcoming Dr. Francis Liu.
Well, thank you, Enrico, for that very kind introduction, and thank you very much for Jonathan for inviting me and to present to you all today. And I'm just curious, how many people here in the room have heard about the DSM-5 Outline for Cultural Formulation or the Cultural Formulation Interview? Could you raise your hands? So maybe about a third. And so there's always more to learn, as they say, and even though the DSM-5 was published in 2013, we can all get a little glimpse of these tools, which I believe you can bring right into your clinical practice, your day-to-day clinical practice, because if you think about it, every encounter with a patient or family is a cross-cultural encounter, because your cultural identity and the cultural identity of those that you serve are really quite different and diverse, and every encounter is a cross-cultural encounter. Here's my contact information, and I have no disclosures here. And so just a very brief outline of my talk today. I'm just going to start with cultural competence. What is it and why? I'll give you my one PowerPoint slide on that. And the two rationales I just wanted to touch on are quality of care and two specific goals of patient-centered care and equitable care, and also the ACGME standards for psychiatry residency training programs. ACGME stands for the Accreditation Council of Graduate Medical Education, and they accredit all residencies and fellowships of all specialties in the U.S. Then, turning to cultural issues in DSM-5, I'll give you a brief roadmap of where that appears in DSM-5. We'll talk about our two tools, and there's also supplementary modules to the cultural formulation interview, which I'll just mention, and I'll highlight some changes from DSM-4 to DSM-5 because there are some important ones to note. And also, to just give you a preview of what's coming down the road, is that I'm involved right now in a process of revising the DSM-5 text revision. As you recall, DSM-4 came out in '94, and in 2000 or 2001, there was the DSM-4 TR, text revision. The diagnostic criteria remained the same, but the text, narrative text, was revised. And so APA has decided to embark on that process, and with a schedule of publication of the DSM-5 TR by the annual meeting next spring. So there will be changes in the narrative involving some of the things that I'll be talking about today. So the Joint Commission that accredits healthcare organizations put forth this definition of cultural competence. The ability of healthcare providers and healthcare organizations to understand and respond effectively to the cultural and language needs brought by the patient to the healthcare encounter. So everything counts in this definition. We can all play a role as healthcare providers at the clinical care level, but we also should be thinking about the healthcare organization, the system's cultural competence. And then there's the understanding, the knowing, and then there's the responding effectively. What are you going to do differently with your knowledge of cultural issues? How does that translate into your differential diagnosis and your treatment plan? That's where kind of the rubber meets the road. And I can't tell you how important that is for cultural competence. And then the culture and language needs. So I always say culture and language, cultural and linguistically competent care. We need to keep that in mind, and it's not just limited English proficiency, but those people with limited sight or limited hearing, they also have language needs. And then brought by the patient to the human, to the healthcare encounter. So this is, when we talk about cultural issues, this is not just some, term in the ether, but this is like right now, right here, you and the patient, you and the family. It's happening every day, actually, okay? So here's my one page on cultural competence. What is it? Well, first of all, I think it's a journey. It's not a, coming to my lecture today will just give you a little glimpse, but it's an ongoing process as we learn more each and every day. So here are the bullet points. First of all, absolutely essential that you start with yourself. Cultural competence is not a spectator sport. You don't just study the other person and we know what to do. No, there's an interactional aspect between you and the patient. And there you must understand what your own cultural identity is. If you have the belief that, well, I'm an American, I don't have a culture, I'm just an American. Well, that's not going to go very far in terms of helping you to understand the cultural identity of the people that you're working with. And with that, related to your cultural identity are your values, prejudices, and biases, and we all have them in some way or another. The next is humility, what some people have called cultural humility, about the limits of our assessment and treatment, knowledge and skills. And to ask the questions. That's the most important thing, is just simply ask the question. Is what I'm seeing here, how much of this is psychopathology, and how much of this might be culture or religious or spiritual? And how much is it kind of a combination of both? Because that often happens as well. To ask that question rather than just simply assume that the person hears a voice that automatically means an auditory hallucination, that means psychotic diagnosis and antipsychotics. Then valuing diversity, and we know importance that is, and then vigilance towards the power dynamics, and always the patient, clinician, there is a power differential, and how that can be accentuated or reduced through the relationship. And then finally, this responsiveness to cultural differences through adapting our assessment and treatment. So now I'm just going to go through some landmark reports, just mentioning them very briefly in case those people in the room are not aware of them, that there's been a whole history here behind this concept of cultural competence. And of course, this is a landmark report kind of looking at our broken healthcare system back in 2001. And they enunciated 6 quality outcomes as goals for a transformed healthcare system. And I'm just going to mention 2 of those: patient-centered care, providing care that is respectful of and responsive to. You see, there's that understanding and responding to individual patient preferences, needs, and values. So very much related to culturally and linguistically competent. And then equitable care, providing care that does not vary in quality because of cultural identity variables. And that's very much related to the healthcare policy driver of eliminating disparities or increasing health equity. That's very much related to that. So the second Institute of Medicine report that came out in 2002 took a deeper dive looking at unequal treatment, confronting racial and ethnic disparities in healthcare. That was the focus of this report. They did not focus on disparities related to other cultural identity variables. And in subsequent work, that has been further looked at. So as you can see, that even controlling for all of these factors, racial and ethnic minorities received lower quality of care. And they looked at why this was so. So there was a whole group of systems issues, and then there were also clinical encounter factors. Again, you and the patient, you and the family. And these are the terms they came up with, that biases and prejudices, stereotyping, and clinical uncertainty on the part of the clinician could contribute to these disparities. And then we also now need to think about how about the patient biases or stereotyping, and how does that play a role in our work together? And then when we talk about biases, there are the intended, the conscious, the explicit, but also the unintended, unconscious, implicit biases. And of course, related to a number of cultural identity variables. I guess it's very painful to see this right now with the news that's been going on. And of course, we need to think about our own personal development that may have contributed to these, as well as our training and our profession. So as you all know, homosexuality was a mental disorder until 1973, and the bias against religion and spirituality goes back to Freud and has been only changing since the 1990s. And of course, the intersectionality of these biases. And here is a third critical report, the Mental Health, Culture, Race, and Ethnicity, Surgeon General, 2001, that looked specifically at disparities in mental health care for racial and ethnic minorities, showing a poor quality of mental health care. A very important report, and the kind of the follow-up to that report is this book edited by Pedro Ruiz, former president of APA, Anel Prim, former deputy medical director of APA, that looked at disparities in psychiatric care not only related to racial and ethnic minorities, but related to a whole series of cultural identity variables, clinical conditions, and so forth. So I do commend this book to you very, very much. Now, turning to the ACGME standards, if you look at the standards, you know there are the 6 core competencies. And so I'm just going to mention a few of these where cultural competence really comes in. So first of all, in the patient care cultural competence, residents must, and must is a very important word in the accreditation standards, demonstrate competence in the evaluation and treatment of patients of different ages, genders, and so forth. So again, looking at the ability of residents to do that. And then taking a deeper dive into that is that residents must demonstrate competence in forging a therapeutic alliance with such patients. Now that's very important because that ties in to the cultural features of the relationship between the clinician and the resident, or the clinician, the patient and the resident, or the patient and the clinician. And in fact, there's a deeper dive in this under the section of medical knowledge. They say there needs to be a specific focus on the cultural elements of the relationship between the resident and the patient, including the dynamics of differences in cultural identity, values, preferences, and power. See, so that's really very much front and center here in the standard. And the final one I wanted to mention was under professionalism. Of course, residents are expected to demonstrate sensitivity and responsiveness to a diverse patient population. So, a roadmap on cultural issues in DSM-5. In the introduction, there are a few pages that review what we mean by cultural issues, and also there's a section on gender differences. Section 2, which is the bulk of DSM-5, in the narrative sections, there are the culture-related diagnostic issues. And if you go to the index of DSM-5 on these pages, you'll see a listing of where this appears in the DSM-5. And also there are gender-related diagnostic issues in the narrative sections. And these things talk about differential diagnosis, prevalence, outcome, and those sections are specifically being reviewed now for updates for the DSM-5 TR. And some of the diagnostic criteria were also revised. I'll just give you one example. And then there's another section of DSM-5 called Other Conditions That May Be a Focus of Clinical Attention. And I just wanted to mention 2 of those conditions. Then in section 3, there's an Emerging Measures section. And here is a section on cultural formulation with the revised outline for cultural formulation that was originated with the DSM-4, but it was buried in the 9th appendix, So you see, one of my purposes in life since the DSM 4 came out was to be like an evangelist, to spread the good news that buried in the DSM-4, there is this outline for cultural formulation that you can use. So here it has been revised, and what's new for DSM-5 is the cultural formulation interview, which I'll mention about much more in a moment. And then finally, in the appendix, there is a glossary of cultural concepts of distress, which replaces that term culture-bound syndromes. So in the introduction, these are just some of the phrases and descriptions here of culture. And if you just take a big picture look at it here, as you can see, this goes way beyond just a focus on race and ethnicity, which often is what people just think about when they say culture, race, and ethnicity. No, there are many, many more things to be thought about in terms of what culture entails. And so the bottom line here is to try to move our thinking about cultural identity and cultural competence, not as a cookie-cutter approach, but rather to understand the intersectionality of this person's cultural identity to provide person-centered care. An example of culture-related diagnostic issues is under schizophrenia. This actually was in the DSM-4, as you can see. Ideas that appear delusional in one culture may be commonly held in another, and that in some cultures, visual or auditory hallucinations with a religious content, hearing God's voice, are a normal part of religious experience. So the debate, for example, of Joan of Arc, when she heard God's voice, was this a hallucination, psychosis, was this a religious experience, things like that. Then, in terms of panic disorder, there is a section, a culture-related diagnostic issues section, but here is one place where the diagnostic criteria actually changed in a small way, reflecting the work of Devon Hinton at Harvard, looking at patients from Southeast Asia who had some of these symptoms that should not be thought of as symptoms of panic disorder. And then in terms of the other conditions that may be the focus of clinical attention, these are the V codes. These are in the back of section 2. And these are conditions and problems that are not mental disorders. So you might ask, well, why are they in the DSM-5 and why are they important? Because they're not mental disorders, so that means they're not billable, so why even care about them? Well, I think that they're here to provide a differential diagnosis and to give you a way of listing problems that the patients may bring to you that are really troubling to them and that you need, optimally, to respond to understand and respond to as part of the comprehensive treatment plan. And many of our patients actually do have a number of these things, and these are very much related, I believe, to the social determinants of mental health. There's a book at the end that I'll reference that really talks about that, the social determinants of mental health, that very much parallels the social determinants of health. And there are two problems that I just wanted to mention to you, to bring to your attention. A religious or spiritual problem, which was introduced in DSM-4. I was one of the 3 people that proposed this for the DSM-4. And so this is a distressing experience that involves a loss or questioning of faith, problems associated with the new faith, or other questioning of spiritual values. So, for example, if you have a mystical experience or a near-death experience that kind of blows your sense of reality, or if you take a psychedelic, and have an experience that is out of the usual state of consciousness, you know. And then you are distressed by these experiences because they're very unsettling. Am I going crazy? And so on. This diagnostic category gives you that opportunity to make a diagnosis that is not a mental disorder. That's the critical piece. These are not mental disorders, but are distressing experiences that patient may bring to you. So to be very concrete about it, a patient comes in and you say, well, what brings you here today? And the patient says, well, you know, I've lost my faith in God. God is punishing me for my sins. Now, how many people in the room here have heard of patients talk along those lines? Wow, that's maybe about at least a third in the room. And so what do you do with that? Do you simply say, well, that's religion, I don't deal with those things, you know, it's best that I not even talk about it? Or are you going to wonder if this is some delusion, or is there some hallucination related to this? Is it a symptom of psychopathology? No, I would argue that it might be useful to think about this as a diagnosis, because you can make this diagnosis and whatever other diagnoses you will be making. I mean, maybe the patient meets all the criteria for major depression. Fine. Major depression and religious or spiritual problem. Put them together on the diagnosis so that you can attend to it in your treatment plan. You know, if you don't know what to do here, you need a further assessment, then call in a pastoral counselor or chaplain. I'm sure those services exist here, and get further assessment as to understanding what's happening. And perhaps this patient may need a religious or spiritual intervention along with your usual forms of treatment. And the patient might feel heard, you see, responded to, and come back, first of all, not drop out, and maybe is more likely to take your medications as part of the treatment plan because they feel like they've been heard. Okay? I mean, one way of stopping the disparities is simply to have patients come back for treatment and to take our medications. I mean, it's that simple, isn't it? And if the patients don't feel heard because these issues are not being attended to, and drop out or not take your medications, then we have problems. And here's another problem in this section about acculturation difficulty. Now, moving on to the outline for cultural formulation, there are 5 parts. What's in yellow here is in the DSM-5, in white is the DSM-4 terminology. And so the first 4 questions are to ask the clinician to gather information about these related fields of information. And then, in the last part, how does this impact on your differential diagnosis and treatment plan? So, cultural identity, cultural concepts of distress, the cultural stressors and supports, the cultural features of the relationship between the individual clinician. You can see the direct line to the ACG and the accreditation standard, and then the overall cultural assessment. Now, there was a DSM-5 task force on cultural issues that Roberto Luis Fernandez from Columbia chaired. I was part of that 30-person work group, and we felt that it would be helpful to have a cultural formulation interview to provide the clinician the 16 questions to use to gather this information. You see what I'm saying? Because that was one of the concerns or critiques of the outline, was that how do you ask the questions? You know, what questions do I ask? So this is to help you do that. So in the DSM-5, there's a patient version and an informant version. And then there are 12 supplementary modules which you can access by Googling Supplemental Modules DSM-5. Right at the top, there's a PDF that you can download or print out. And these are like deeper dive questions on particular topics in the outline for cultural formulation, as you can see here. Deeper dives into this. But then also towards the end, there are question modules related to, for example, school-aged children and adolescents, older adults, immigrants and refugees, and about religion and spirituality. So I think those are particularly important if you are working with those populations to use these questions to help you further your understanding of the patient. So this is what it looks like in DSM-5. As you can see, it's not just simply a list of the 16 questions, but rather there's the guide to the interviewer here, and then there are the instructions and the language that you might want to use. And you see the very first question here is, what brings you here today? So, hopefully you're asking that question now, you see. So you've got one of the 16 already, okay? And so I'm going to now spend a little bit of time going through the CFI in sequence. Okay, and then relating that back to the outline for cultural formulation, because they're not in exact sequence. And why is that? Well, as you can see in the outline for cultural formulation, cultural identity was the first one that was listed. And we thought that it would not be very helpful to start the interview with, well, can you tell me what's the most important part of your background or identity? That's not exactly how you would start an interview. That might be a little, difficult for a patient to answer that, like right off the bat, you see. So we thought the place where you start an interview is what brings you here today, you see. So that's where we start. But that's not the cultural identity. Do you see what I'm saying? So I'm going to go through the sequence of the CFI and relate it back. So these are the first 3 questions. The first 5 questions are around the cultural definition of the problem. What brings you here today? And then sometimes people have different ways of describing their problem to their family, friends, or others. How would you describe your problem to them? Now, problem here is in caps and brackets because we would like you to use the patient's words whenever possible. A patient may say, well, what brings you here today? Well, wind illness. Well, then, how do you describe your wind illness to them? And then what troubles you most about your problem? Now, this question relates to how does it relate to the patient's social network or family? And we will see this kind of pattern in a number of the questions that follow. Then the next 2 questions relate to explanatory model. This goes back to Arthur Kleinman, 1979, where he talked about explanatory model in psychiatry. And so why do you think this is happening to you? What do you think are causes of your problem? And then how does this relate to your social network? So these first 5 questions tie in with the cultural concepts of distress, and these are quotes from that section 3 where this is further described. How the individual experiences, understands, and communicates symptoms. And there are 3 subtypes: cultural syndromes, idioms of distress, and explanatory models. So idioms of distress are like the little building blocks, and the cultural syndromes are a collection of them, if you will. Okay? And so important here is to assess the severity and meaning of all of this in relationship to the norms of the cultural reference group, and to assess the coping and help-seeking patterns And that part of this part B we'll see later in the CFI. I'll come back to that. Now, what are these cultural concepts of distress? Can you give me some examples? Well, right there in the appendix, there is this glossary, and it provides 9 examples of well-studied cultural concepts of distress. And so, as you can see here, names, these are the types. So you can see there's syndrome, explanation, idiom, and some of these are related. So nervios is an idiom of distress that is part of the ataque de nervios, which is the syndrome, the clinical syndrome. And then these are places around the world where this is often seen. And of course, we are helpful for us to know about that because we. And so, a book, if you're not aware of this book, highly recommend the Hmong family from Southeast Asia felt that this was a shamanic opening. They had a different understanding, a different explanatory model and treatment method. And unfortunately, they never talked about that, and it led to non-compliance with the medication, and the child had a very long grand mal seizure and became a vegetative state, and she died a few years ago, actually. So this is kind of the default position that we're trying to avoid by recognizing these explanatory models and treatment pathways so that we can negotiate with our patient. Next 2 questions relate to stressors and supports, as you can see here. And so this relates to part C, and again, in the DSM-5, in the DSM-4, there was specific mention of religion and family. If you just remember, religion and spirituality and family. Added for DSM-5 was other social networks and the concept of resilience. So, Pamela Hayes has written a book which is referenced. The idea here is we're always looking for ways to support our patients, and how can we enlarge that radar screen or that lens so that we can include this in our thinking. And here are some more, and here are some more. And some unusual ones, and we know how important caring for animals can be. You know, pet therapy and so forth can be very important for some of our patients. And so, looking at family, the questions are who's in the family, a genogram, looking at not only nuclear family, but extended family. And a critical book that I recommend is Ethnicity and Family Therapy, 50 chapters, not only about Chinese families and Vietnamese families, but also Russian families and Italian families and Irish families. In terms of stressors, thinking about intrapsychic stressors, cultural identity conflict. I was born in San Francisco of Chinese parents. Am I an American? Am I Chinese? These kinds of conflicts. Sexual orientation conflict. Am I gay? Am I straight? And these could, cause significant stressors. And interpersonal between family members, where the usual scenario of the traditional Vietnamese family, limited English proficiency, immigrant parents, and you have the adolescents that are born here and speak English only. So even though they share the same ethnicity, they have very different cultural identities, and this could lead to value conflicts and interpersonal stress. And then the other conditions of clinical tension and the social determinants of mental health. So here are books that I would recommend on that, especially the Pamela Hayes book and the Monica McGoldrick book, Ethnicity and Family Therapy. Then question 8, the role of cultural identity in terms of, for you, what is the most important aspect of your background or identity? And the follow-up questions are, does it make a difference in your problem? And can you say more? So this relates to Part A, the cultural identity. This is what was in DSM-4. As you can see, race, ethnicity mentioned, immigrants, and language. Added in DSM-5, very important that it explicitly acknowledges that these are also cultural identity variables to think about and consider. And this brings up the whole issue of intersectionality. How do these all intersect to bring us to the cultural identity of the person in front of us? So Pamela Hayes, in her book, Addressing Cultural Complexities in Clinical Practice, has the acronym addressing with all of these different cultural identity variables. There's no L in addressing, so language is not mentioned there, but the concept is to go beyond race and ethnicity to look at all of these factors. And the important thing here is ask, don't assume. That's part of cultural humility. Ask, don't assume. As you can see, there's a lot of complexity here that we sometimes just gloss over. And why is it important? Well, critically important is that it does influence the other aspects of the outline and can be a source of distress or support, as I mentioned earlier. Now, moving on to the next few questions, this gets back to the coping and treatment pathway process in terms of how have people coped with this in the past, and has anything prevented you getting care, the barriers, and then, again, this is where the rubber meets the road. What kind of help do you think would be most useful for you now, you see, and also of your family? You're really trying to engage the family and the patients into participating in the treatment plan. So this relates back to that part of the cultural concepts of distress. Different methods. The last question is this one on the clinician-patient relationship. In retrospect, I think this could have been worded a little better, but the concern about differences in backgrounds between you and the patient, and is there anything we can do to provide the care that you need? So this relates to a very important Part D. Again, what was in yellow here is added. Identify the differences between the clinician and the patient and the difficulties this may cause in diagnosis. And experiences of racism and discrimination in the larger society may impede establishing trust and safety. And also difficulty maintaining a therapeutic alliance, coming back to the ACGME requirement. So how do you do this? Well, first you start with yourself, understanding your own cultural identity. Secondly, compare the cultural identity of yourself with that of the patient. Okay? And for each of those factors, look at how that impacts the relationship. These are issues we think about all the time in terms of empathy, communication, how do you elicit symptoms, stigma, shame, transference and countertransference. This is par for the course. I'm just suggesting that we add a cultural lens that might make a difference. So let me give you some very, very concrete examples. I'm a man. A woman comes in. She seems a little reluctant to give me history. And then at the end of the interview, she says, well, I really would feel more comfortable talking with a male doctor. Okay, well, what does that mean? Do we immediately jump to, patient is non-compliant, patient is not responsive, patient is passive-aggressive? I mean, do we go right to there, or do we just ask the simple question? Well, there's a cultural identity difference here, male and female, and could it be that the patient, because of sexual abuse history, is a little reluctant to give us much history? Okay, I'm an atheist. A patient walks in who's a Roman Catholic, attended church weekly for the last 30 years. And she says, well, I've lost my faith in God. And me, well, I'm an atheist. I don't believe in God. Cultural identity difference, you see. So how is that going to affect the transference, the countertransference? Could I inadvertently reveal biases? I could say, God, tell me about God, in a questioning sort of way. And that could lead to the patient feeling unheard and drop out of treatment. So those are just some examples of all of this. Right, we need to look at our own biases. And another way of looking at this question here, I think in a very helpful way, is what would help the clinician to provide optimal care? That could either be cultural identity matches or knowledge and skills. So for some patients, a patient comes in, speaks only Cantonese, I only speak English. There is a difference there. So in that particular case, I think a Cantonese-speaking clinician matching the Cantonese language ability of the patient would be very helpful to provide care. It's an obvious one, right? But sometimes, for other things, that kind of match is less important. And then knowledge and skills in working with those patients is what's important. And again, ask for a consultation. Very important. Ask for a consultation. Know the limits of your knowledge and skills. Ask for a consultation. So the last part here is the overall summary and 2 points. One is differential diagnosis. We want to avoid a misdiagnosis. I mean, we're all interested in an accurate diagnosis. So I'm just suggesting if you add a cultural lens here to what you're already doing, perhaps there may be occasions where this will lead to a more accurate diagnosis, because we know, bottom line, misdiagnosis can lead to mistreatment, which we want to avoid. And these are the factors. If you don't understand what the idioms of distress or the syndromes are, or the explanatory models, you don't have an adequate relationship to gather the history, the patient's reluctant to tell you history, and also the clinical bias, stereotyping, and clinical uncertainty. And then in terms of treatment planning, two aspects. One is the process of negotiating and managing a treatment plan to maximize adherence compliance. And then there are the content issues. And so the whole area of pharmacodynamics and kinetics related to genetics, but also gender, also age, and beyond those things are things like diet and smoking, and all of these things can interact to cause us to think about medications and what are ways of increasing compliance with medications, and how do we combine our medications with other biological approaches such as acupuncture. Maybe some patients need both the antidepressant and the acupuncture. Then in terms of psychotherapy, my colleague Evelyn Lee, who was a pioneer in Asian mental health, who passed away suddenly at age 59 from a heart attack, used to say, when treating traditionally acculturated Chinese patients, be the tiger balm oil at the first interview, meaning that those patients often have the treatment expectation of some relief, some small relief in the first interview. And so if you don't know that patient expectation and don't meet it, the patient may drop out of treatment. And then the usual questions about what kind of therapy. Some patients would feel family therapy would be very important, and so on. And here again, utilizing the family, spiritual, religious, beliefs and practices, faith communities can be important, and so on. In terms of further resources, 3 books I would recommend. The Clinical Manual of Cultural Psychiatry, 2nd edition, edited by Russell Lim, which focuses on the outline for cultural formulation, has video vignettes, won a Creative Scholarship Award from the Society for the Study of Psychiatry and Culture. The Handbook on the CFI, 2 video vignettes, and the Social Determinants of Mental Health, API books that were recently published that I would highly recommend. You can see there are chapters on documented evidence for social determinants of mental health, and so very concisely giving you this information on all of these different factors. And the last is the Society for the Study of Psychiatry and Culture, and I think that's it. Thank you very much. Do we have a microphone for questions? All right, so I'm going to run the mic here. So we have a mic over here, and any questions, comments?
Thank you for the great talk. Can you speak more about being the tiger balm oil at the first visit?
Yes, well, tiger balm oil is a little salve that you put on for like pain, and is used in like Hong Kong and in a number of Chinese cultures, and it's over the counter and so on. And so again, the idea was the patient family expectation is some relief in the first interview, and so be able to provide that psychologically at the first interview. So if the patient, major depression, blah blah blah, patient is not able to sleep, well, address that, provide some immediate help. Yeah.
Thank you.
Thank you so much for that great talk, Dr. Liu. As a APA diversity leader fellow, I also received Dr. Ruiz's and Prim's book, and I was really shocked, I guess, at the glaring disparities. Coming from Canada, I was one of 5 psychiatrists who spoke Mandarin and actually worked with Mandarin-speaking patients, and I'm just mulling over what you've presented and wondering if you have thoughts on how to close those gaps for people who do come from non-white, non-English speaking backgrounds, because I imagine the training situation here is very similar even in a metropolitan place like LA or California.
Well, I think there's many ways to approach this. I do think as I say, some cultural identity variables like language, I think is really more important in terms of communication. So recruiting people who can speak those languages is so important, okay? Also, dealing with immigrants and refugees, I think, if people are immigrants and refugees themselves, they may have greater empathy about those situations. Patients may feel more comforted by that. That might be important. Secondly, I think is education for everybody, because all of us are seeing patients like this day in and day out. And how can we, even though we don't have those particular backgrounds and so forth, how can we provide care? That's a reality. And I think that one approach that was pioneered at McGill is a cultural consultation service. There's in fact a book called The Cultural Consultation. Lawrence Kiermaier is a lead editor there. And it's a beautiful concept of the cultural consultation service to provide consultation, just like we have psychopharmacology consultation, psychotherapy consultation. I think the idea of a cultural consultation service would be just tremendous. So if you have a case where you have a question about diagnosis or a treatment plan is not working out, getting a consultation can be very important. And then thirdly, of course, which we haven't talked about at all here today, is systems cultural competence. And I just want to recommend very highly the CLAS standards, CLAS. That stands for Culturally and Linguistic Appropriate Services Standards. This comes out of the Office of Minority Health in HHS, originally in 2001, revised for 2013. And the website is thinkculturalhealth.hhs.gov. thinkculturalhealth.hhs.gov. And just placed on there, within the last month, is an online training on culturally competent care for behavioral health care providers. And it includes elements of the outline for cultural formulation and the cultural formulation interview. And you get 5 CE credits for free. Okay, the CLAS standards goes over systems cultural competence standards. Very important.
Thank you for the really excellent and important talk. One thing that comes up frequently is when we have patients that say something that we consider morally objectionable or morally reprehensible. Oftentimes those sentiments are core to a patient's culture. So whether it's an older male veteran who makes a very demeaning comment about women, whether it's the treatment of a neo-Nazi, for example, how does the cultural formulation play into that? Does it offer any guidance in those scenarios?
Yes. Well, again, just your posing that question, you see, gets right to the cultural elements of the relationship between the clinician and the patient. And I've just kind of touched on this, kind of just opening the door, hopefully, for you to explore this further, is, what's your cultural identity? What's the cultural identity of the patient? I'm assuming, I won't ask you. I'm assuming you're not a neo-Nazi, and the patient is a neo-Nazi, and then how does that affect us? What's our countertransference to that? And what will happen in the transference if the patient somehow gets the sense, well, you're not a neo-Nazi, then who are you? Are you one of those Obama supporters? And then how's that going to affect the relationship? So these are, to be just aware that this cultural identity, first of all, be aware of the similarities and differences, and how is this going to affect the relationship. So there's a lot to that, okay, a lot. And in this day and age, that's even more important, because we are seeing people, who have, the neo-Nazi or other kind of political orientations that we may not feel comfortable with ourselves, and how do we deal with that? Now, hopefully, you'll be able to deal with this in supervision, and if not, well, faculty development activities may be needed to help people really talk about this. Because it's out there now. I mean, this is being talked about at the medical school level, is the kind of the comments of patients like, I want a real doctor, or, where are you from? These are the questions that do come up and affect the clinicians. And how do you deal with that? It's a real problem now. Yeah. Other questions?
Well, I think we're actually just about out of time, but thank you very much, Dr. Liu, and thank you guys for coming.